Hi, my name is Brady Williams, and I'm a family nurse practitioner student at the University of Southern Maine. Today I'm going to be discussing the practice of delayed antibiotic prescribing for acute respiratory infections. I'd like to begin by setting forth a few of the objectives for this presentation. First, I'm going to review the extent and the consequences of the antibiotic overprescribing problem, mainly in the United States. I want to introduce the concept of just what a delayed antibiotic prescription is and what it means. Then evaluate the evidence for the practice and really get into the available data suggesting whether the practice works or not. And then finally, I'm going to discuss some strategies for implementing delayed antibiotic prescribing in the case of uncomplicated respiratory tract infections. So to start with a little background here, each year in the United States, there's about 270 million courses of antibiotics dispensed that were prescribed on an outpatient basis. Now, this represents a vast majority of all antibiotic prescriptions. Some estimates say that about 80 to 90% of all antibiotics are prescribed for outpatient use. We can see that this roughly represents 5 prescriptions for every US citizen, so almost one for each American. And they're most commonly prescribed for urinary tract infection, gastrointestinal ailments, skin infections, and respiratory tract infections, or RTIs. Most frequently used antibiotics are azithromycin, amoxicillin, augmentin, ciprofloxacin, and cephalexin, or Keflex. And the prescribing of antibiotics follows a seasonal pattern that matches the seasonal pattern of mainly of respiratory illness. So it's 42% more likely for an antibiotic to be prescribed in February than it is to be prescribed in September. So who is prescribing most outpatient antibiotics? Well, unsurprisingly, the leading prescribers are primary care physicians, followed by nurse practitioners and physician assistants. This is compared to very few antibiotics prescribed, relatively speaking, in an emergency medicine setting. Now, 44% of all antibiotics are prescribed for acute respiratory tract conditions. Now, I held off from saying infection because, as you'll notice, several of these are not from infectious etiologies. So sinusitis, ear infection, pharyngitis or sore throat, viral upper respiratory tract infection, bronchitis, bronchiolitis, asthma, allergy, influenza, and pneumonia. But right off the bat, we can see there's a little bit of trouble here because a lot of these conditions for which antibiotics are prescribed are in fact viral or immune mediated and are not bacterial at all. So just to encapsulate this, if we can think of a typical antibiotic prescription in the US, well, it would be prescribed on an outpatient basis by a primary care physician, probably for some sort of respiratory issue. So antibiotics are incredibly important. According to the CDC, they're the most powerful tools that we have to fight life-threatening infections, like those that can lead to sepsis. And to that, I would add perhaps preventing gangrene in the case of skin infections, preventing abscesses and rheumatic fever, heart valve complications in the case of strep, or preventing respiratory distress in the case of pneumonia. But as our friends from across the pond remind us, no amount of antibiotics will get rid of your cold. They're quite serious about antibiotic education over in the UK. So antibiotics can be wonderful, but are not appropriate in the setting of viral illness. So nevertheless, it's estimated that approximately 30% of all prescriptions for antibiotics are unnecessary. And if you follow down to this second table, this is even worse for acute respiratory conditions. About half of all antibiotics prescribed are unnecessary, and particularly within the 20 to 64-year-old cohort, uh, roughly 70% are deemed unnecessary. Now, where do we get these numbers? Fleming, Dutra et al., in conjunction with the CDC in 2016, published this data. And what they did is they looked at the National Ambulatory Medical Care Survey and then looked at the guidelines for each presenting complaint and assessed whether antibiotics were correctly used in each case, and their answer was a resounding no. So if we drill down to individual patient presentations, these antibiotic prescribing numbers can look even a bit more egregious. So, out of all adults that present with strep throat, roughly 18% will have group A strep pharyngitis, strep throat, and that's essentially the only indication for antibiotics other than some much more rare diseases. Now, 72.4 of these folks end up getting antibiotics. And secondly, antibiotics are never indicated for acute bronchitis, but are prescribed about 70% of the time. Similarly, acute sinusitis is bacterial in about 2% of all cases, while 80% of visits result in a prescription. So if we do a little back of the envelope math here, we've got 270 million outpatient prescriptions per year. Multiply that by 44% of which are for respiratory ailments. Multiply that by about half being unnecessary. And we've got roughly 60 million unnecessary antibiotic prescriptions annually in the United States just for respiratory complaints. Now, this number may actually be a gross underestimate. Recent research shows that in urgent care centers, which are a growing segment of our healthcare economy, antibiotics are frequently inappropriately prescribed at rates twice that of other settings. So this 60 million number may actually be quite low. Why do we prescribe when we don't need to? Well, we don't know in every single case, but we do know that physicians' perception that a patient wants antibiotics, not the fact that the patient themselves necessarily wants antibiotics, but the physician's perception that they want them is strongly associated with prescribing antibiotics in the case of respiratory tract infection. So perhaps this is a desire to maintain a good patient-provider relationship, or perhaps keep patient satisfaction ratings high as they're increasingly tied to provider compensation. Or it might just be that they're in a busy office setting and the patient wants antibiotics and you got to move on to the next person. And they just want to conclude the interaction and say, here's your prescription. So why do we really care about this overprescribing? After all, we're not talking about opioids here. We're just talking about antibiotics, right? Well, about $9 billion in total healthcare expenditures are attributed to antibiotics. So if we assume that about 30% are unnecessary, we have roughly $3 billion in cost savings that could be achieved if we prescribed appropriately. Now, the entire Medicare budget is north of 500 billion, so this may seem like a drop in the bucket, but there's probably a lot of other good things that $3 billion could be spent on. Secondly, although I think most patients often assume that most antibiotics have a relatively benign side effect profile, this isn't always the case. Some frequent ones are nausea, vomiting, diarrhea, skin rash, and then also they can be responsible for quite a few adverse reactions. Roughly 140,000 emergency department visits per year are attributable to antibiotics. And about 80% of these are for allergic reactions, not all of them anaphylaxis, but some of them certainly. And in total, about 1 in 5 of all emergency department visits, for medication-related adverse events were for antibiotics. Now, in thinking about some of the more serious adverse reactions, we have seizures and tendon rupture associated with fluoroquinolones, for which there's a black box warning. We have sun sensitivity and esophageal ulceration with doxycycline, particularly if the patient suffers any reflux immediately after ingesting the pill. Hyperkalemia in the case of Bactrim. Sometimes we can get renal toxicity and ototoxicity with aminoglycosides. The renal part is often reversible, but sometimes the oto part is not. So people can get irreversible hearing loss from aminoglycoside antibiotics. Liver injury in the cases of long courses of Augmentin. And with any of these drugs, or many, we run the risk of Stevens-Johnson syndrome, again, quite rare, but very serious and sometimes fatal. So why else do we care about antibiotic overuse? Well, Antibiotics can cause important changes in the normal microbial composition of our bodies. And what it can do is often eliminate or reduce the so-called good bacteria, allowing room for more pathogenic microbes to proliferate. So one example of this is the increased incidence of genital yeast infections while people are taking antibiotics. But also, far more dangerously, it can give rise to a C. diff or Clostridium difficile infection. This nasty critter is pictured over here on the right. And part of what makes it so difficult to eradicate is that in its dormant phase, it's very good at surviving for long periods of time on hospital surfaces or room surfaces. It forms what's called an endospore, which is extremely heat and cold tolerant. That's why we use bleach wipes in the hospital to clean everything after someone has had a C. diff infection. C. diff is extremely serious. It can cause intestinal rupture. It can cause very severe diarrhea, dehydration, and although it's not often fatal, there are about 15,000 deaths out of 500,000 infections annually. That's still a significant number of deaths, and it adds about $6.3 billion in annual healthcare costs. Now, this statistic really shocked me. The risk of C. diff infection is 7 to 10 times greater immediately after a course of oral antibiotics. And I guess I just didn't know that it increased it that much. I think clindamycin, I've heard, is particularly notorious for being one of the culprits that eventually leads to C. diff infections.